We described the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. We distinguish between influenza and other respiratory infections, and we designed a therapeutic regimen for influenza. We also listed the likely causative pathogens for rhinosinusitis and pharyngitis. Now, given a patient with acute bacterial rhinosinusitis, recommend an appropriate therapeutic regimen. These are the 2012 IDSA guideline recommendations for bacterial rhinosinusitis, and they do recommend that empiric treatment should be initiated as soon as possible if you suspect bacterial rhinosinusitis, and this is for the purpose of shortening the duration of illness and to provide earlier symptom relief, restore quality of life, and also to prevent recurrent infection or suppurative complications. Now, keep in mind that the common pathogens for bacterial rhinosinusitis are the strep pneumo and strep pyogenes, which are gram-positive, and H. influenzae and Moraxella catarrhalis, which are gram-negative. Gram-positives stain blue on gram stain, so they are positively blue for you, and gram-negative organisms stain pink on the gram stain. So that's the primary difference between those two. So the preferred drug of choice for acute bacterial rhinosinusitis is amoxicillin-clavulanate, and that's recommended over amoxicillin because H. flu and Moraxella catarrhalis are likely to produce beta-lactamases, which will break down amoxicillin. Clavulanic acid will actually block those beta-lactamases. So amoxicillin-clavulanate is first choice. Now, if someone has risk factor for drug-resistant strep pneumo, you can also use a higher dose of this to overcome the resistance in strep pneumo. So 2 grams twice a day of amoxicillin-clavulanic acid. Now, alternatively, if for some reason someone could not tolerate amoxicillin-clavulanate, we can consider doxycycline. Now, the reason this is an alternative is because doxycycline does not have best activity against drug-resistant strep pneumo. However, this is considered alternative because it does have good activity against H. flu and Moraxella catarrhalis. So, but if someone can tolerate amoxicillin-clavulanic acid, they should receive that first. Now, the guideline says that beta-lactam agents are preferred over respiratory fluoroquinolones for initial empiric antimicrobial therapy. And that's a very good recommendation. And, as we know, respiratory fluoroquinolones are more likely to cause collateral damage. And also to add more to it, in 2016, the FDA added to the black box warning for fluoroquinolones. So this is from the levofloxacin package insert, where the black box warning is serious adverse reactions, including tendinitis, tendon rupture, peripheral neuropathy, and central nervous system. And more specifically, the FDA said because fluoroquinolones, including levofloxacin, have been associated with serious adverse reactions, which are listed above, you should reserve levofloxacin for use in patients who have no alternative treatment options for the following indications. So that includes urinary tract infections. So someone with uncomplicated urinary tract infections, if they have options, they should receive those other options. So only use fluoroquinolones if there are no other options. The same is true with bacterial sinusitis or rhinosinusitis. So if someone has, if someone can tolerate amoxicillin-clavulanate, then they should get that instead of levofloxacin. Now, these are the things that you should avoid. So macrolides, so azithromycin does not have good activity against drug-resistant strep pneumo, so that should be avoided. Trimsulfa does not have good activity against drug-resistant strep pneumo or H. flu, so it should be avoided. Second and third generation oral cephalosporins do not have good activity against drug-resistant strep pneumo, so they should be avoided. And of course, clindamycin does not have activity against gram-negatives, so monotherapy should not be used. So if you are to use clindamycin, you should also use a second agent to cover H. flu and Moraxella catarrhalis. and clindamycin is also associated with Clostridioides difficile, and it's likely to cause collateral damage. It does have activity against gram negatives, so clindamycin should also be reserved last line for people who cannot tolerate other things. And even then, it should not be used as monotherapy. It should be used in combination. So in patients with penicillin allergy, it's recommended to either use doxycycline or respiratory fluoroquinolone. So this is where using a respiratory fluoroquinolone is okay, because now the patient has allergy to penicillin, so they can no longer take augmentin. So now it's okay to use fluoroquinolones because the patient is running out of option. And doxycycline, so you might choose fluoroquinolone over doxycycline because doxycycline doesn't work well against drug-resistant strep pneumo. But if the patient doesn't have risk factor for drug-resistant strep pneumo, then they can totally use doxycycline because it will have good activity. Now, there are also some recommendations for adjunctive therapy. So intranasal saline irrigation and intranasal corticosteroids can be helpful in conjunction with antibiotics. The IDSA does not recommend topical or oral decongestant, and they also do not recommend antihistamines specifically for bacterial rhinosinusitis because of lack of efficacy. Lastly, the duration of therapy for acute bacterial rhinosinusitis is 5 to 7 days regardless of which agent is used.